Well, good afternoon, everybody, both to those in the room and those who are listening as part of the live stream. I'm Liam Donaldson, and I'm chair of this new integrated care board for the North East and North Cumbria. Before I introduce members of the board and say a few words about the agenda today, I just wanted to make a brief introductory statement. The Integrated Care Board was inaugurated today, a few hours ago, and we're one of 42 such boards around the country. We're taking responsibility for the planning, development, organisation and funding of services using a very large NHS budget, something over £6 billion, to provide and plan care for a population of around 3 million people. Taking responsibility over from the 8 clinical commissioning groups who used to do those functions for the last 10 years. And I'd like to begin by thanking the chairs and boards of the CCGs, the clinical commissioning groups, for all the hard work that they've done over the last decade, and for all the things that have been achieved. And we'll very much endeavour to build on those achievements that were secured in a very, very complex environment of health and healthcare over that decade. I'd also like to thank the staff of the clinical commissioning groups, but they're moving over to become staff members of the Integrated Care Board, so we'll be able to continue to use their expertise in our work. Someone said a long time ago that all politics is local, and I've sometimes wondered if we could borrow that expression and say that all health is local. In fact, most of it is, and indeed, it's a good point to start thinking about the Integrated Care Board's role, because we're very determined to ensure that the populations and neighbourhoods in the 3 million population around this integrated care system area, and particularly the 13 places that make up the integrated care system, are absolutely first and foremost at the heart of our work. But not every aspect of health is local. We're working in a national health service with certain plans and goals and responsibilities to discharge. Most of them will be delivered at local level, but there may be some of them that we'll do on a larger scale over the entire 3 million population, particularly when it comes to spreading the benefits that have been devised in some of the expert work that goes on at national level. And then while I was Chief Medical Officer for 12 years, one of the reports I produced was entitled All Health is Global. And that was the first global health strategy that the UK government had ever produced. And while it was a bit of an exaggeration, it was intended to draw attention to the connection between countries and localities within countries and things that are happening at a global level. And we've seen that played out most dramatically over the last 2.5 years with, of course, the COVID-19 pandemic, a threat that applied to us here and to all our smaller communities and neighbourhoods, but a threat which was also a global threat. And there will be more of those in the future. And one of the key areas of work that we need to do at an early stage is to put in place the resilience plans and the emergency plans that can enable us to cope with further threats. The threats don't all come from potential infectious disease agents, whether viruses or others. There's the whole question of the global impact of climate change. And a lot of great work's gone on in the ICS before we came into being to try and work out the best ways of playing our part in the work necessary to mitigate the threat that that poses to our populations. But global health also contains the concept of globalization. And we know that when we look at some of the wider determinants of health, the way that what we eat, how our young people form their attitudes to life, all of those things are determined not purely by local forces or even forces within our own country, but they're part of the waves that sweep across globally and influence human behavior and access to the benefits of health. And then finally, we have the opportunity to learn from some of the innovations that are being developed globally, not just in technology, but also in medicine and the organization of services. So whilst our focus is on health locally, and that will remain the centerpiece of our work, we have to recognize that interconnectedness, both the threats and things that we have to combat, but also the benefits and the understanding that can come from having not just a local perspective, but a national perspective, and on occasions, a global perspective. Right at the forefront of our work, of course, will be a challenge that this region has faced for a long time. Some very good work has been done to try and combat it, but the whole question of health inequalities and the high levels of preventable disease and premature death that affect this part of the country disproportionately. So that will be something that we will have early action on, and we'll be helped in that with a partner board that's going to be established as part of these new statutory arrangements, the Integrated Care Partnership. That's set up slightly behind the Integrated Care Board in timescale, but it's certainly not behind it in importance. And we look forward very much to working, particularly with our local authority partners, in establishing that in the near future. But whilst we're talking about health inequalities and preventable disease and preventable early death, I can't leave today without mentioning that it's the 15th anniversary of the bringing of smoke-free public places and workplaces to this country. It was something I was particularly associated with when I was Chief Medical Officer, and I can remember going out as part of the launch that the Department of Health Communications Department set up for me around pubs in London with an umbrella because it was pouring with rain, with a great deal of anxiety that everybody would defy the rules and carry on smoking. It didn't happen. People respected the rules, and it's been a great pleasure, I think, to see the way that health and that aspect of health has benefited from that change. But the North East and North Cumbria has been a part of the country that's done some brilliant work on tobacco control. It's still, although we shouldn't isolate single factors, but if you do look at single factors, it's still the biggest contributor to health inequalities in this country. So a lot of good work's already been done to turn that situation around, but tobacco control will be, again, at the heart of our work on health inequalities, and I look forward to talking to all the people who've been passionately working on that over the last decade or so. So that's all I wanted to say by introduction, except to add that you see around the board today a group of people, but also a group of partners. And if the Integrated Care Board is to stand for anything, it should stand for strong partnership. That's why it's been created. And we will achieve through partnership, things that we could never hope to achieve on our own as organisations. So that's going to be our philosophy as we move forward, with the health of those 3 million people and the health care and care that they can access also being at the top of our agenda. So I'm going to ask individual members of the Integrated Care Board to introduce themselves and say which organisation they work in. And then I'm going to say a few words about the agenda and how it's being formed, because it isn't a typical agenda. You won't see this sort of agenda in the future, because we're having to take on board a lot of statutory and governance items in order to bring ourselves properly into being. But if we could start and turn to my left.
Thank you, Chair. Hello, my name is Sam Allen. I'm the Chief Executive of the North East and North Cumbria Integrated Care Board.
Hello, I'm John Rush and I'm a non-executive director for the board.
Good afternoon, I'm Jacqueline Myers and I'm the Executive Director for Strategy and System Oversight for the ICB.
Hi, good afternoon. I'm Rajesh Nadkarni and I'm the Foundation Trust Partner Member here, but also Medical Director and Deputy Chief Exec at CNTW NHS Foundation Trust.
Afternoon, Annie Laverty, and I'm the Exec Chief People Officer for the Integrated Care Board.
Good afternoon, I'm Tom Hall. I'm a Director of Public Health for South Tyneside and one of the local authority partner members.
Hello, I'm Eileen Kainer, Professor of Public Health and Primary Care Research and Director of the Applied Research Collaboration covering the North East and North Cumbria, and a Non-Executive Director.
Good afternoon, I'm Mark Adams. I'm Executive Director of Place-Based Delivery covering North Cumbria and the North for the ICB.
Good afternoon, I'm Mike Smith. I'm a GP in County Durham and I'm one of the Primary Medical Services partners.
Good afternoon, David Thompson, Chair of Health Watch Northumberland, but here representing the 13 Health Watchers within the network of North East and North Cumbria.
Afternoon everybody, I'm Jackie Auld. I'm the Director for Children's Services and Director for Adult Services in North Tyneside Council, and here representing the Directors of Children's Services from a local authority perspective.
Good afternoon, I'm Neil O'Brien. I'm the Executive Medical Director for the North East and North Cumbria ICB.
Good afternoon, I'm Sarah Malik. I'm a Sunderland GP and I'm also one of the Primary Medical Services partner members.
Good afternoon everybody, I'm David Gallagher. I'm the Executive Director of Place-Based Delivery for Tees Valley and the Central Patch.
Good afternoon, I'm Anne Workman, Director of Adults and Health at Stockton-on-Tees Borough Council and the local authority rep on adult social care.
Good afternoon everybody, Graham Evans, Executive Chief Digital and Information Officer for the Integrated Care Board.
Good afternoon, Ken Bremner. I'm a Foundation Trust Partner Member, but I'm also Chief Executive at South Tyneside and Sunderland Foundation Trust.
Hello, I'm John Connolly. I am the Executive Director of Finance for the ICB.
Afternoon, I'm Ijaz Zahid, Executive Director of Innovation for the North East and North Cumbria Integrated Care Board.
Afternoon, my name is Claire Riley. I'm the Executive Director of Corporate Governance, Communications and Involvement for the Integrated Care Board.
Good afternoon, I'm Jan Thwaites and I'm the Governance Officer and I'll be taking your minutes today.
Okay, well thank you, Jan. We are in beautiful surroundings here with the new Sunderland City Hall, and I'm told it's part of a regeneration programme for this part of the city, and indeed very relevant to our recent work in the NHS. The new Sunderland Eye Hospital is going to be located a short walk away from here, so we look forward very much to seeing these further developments come together, and very symbolic for us, I think, on this day that we're not too far away from our latest capital development, which is the new Sunderland Eye Hospital. So Jan, could you tell us about apologies for absence today?
I can certainly. I have Hannah Bowes, the Independent Non-Executive Member for PPI, David Stout, the Interim Independent Non-Executive Member for Audit, David Purdue, the Executive Chief Nurse, and Kath McAvoy Carr, the Local Authority Partner Member Designate.
Thank you very much, Jan. And just on the question of declarations of interest, which is also on this agenda item, you've all submitted your declarations of interest. And this is just to ask if any has any additional thing they wanted to mention that has arisen since you put in your declarations. Then just to flag up that we, like a lot of other things, in order to become legal, we've adopted the Clinical Commissioning Group's format for declarations of interest, and we intend to extend the remit a little bit of that, or extend the basis of the declarations, because at the moment it's tied very specifically into any conflicts with the commissioning process, but the ICB has a wider role than commissioning, so we'll make sure that over time those go into the public domain. Then item 3 is the constitution and standing orders. There's enclosures 1A and B that cover that. It's an item for information, as it's already been approved by NHS England, but does any member of the board want to raise any points with that? Okay, thank you very much indeed. Moving on then to, and some of these matters will, as I said earlier on, appear very procedural, and they are very procedural and statutory. We will have the opportunity on a couple of items to talk a little bit more about the work we're planning to do in patient and public involvement and health inequalities, but we'll come to those later on the agenda. So if we could move then to item 4, which again is largely for information. It is the handbook and functions and decision map. Again, a national requirement for the new ICBs to produce documents like this. But I'll pass over to Claire Riley to explain the background to this.
Thank you, Chair. Just before we do go into talking about a suite of governance materials, I just wanted to pay tribute to a number of people who have got us to this point, and I think it would be remiss of us not to reference the work that they've done. So we have Dan Jackson, Nick Bailey, Ali Wilson, as well as the corporate governance leads across the North East and North Cumbria who have worked together on a large suite of documents from a corporate governance point of view, in particular Deb Cornell, Irene Walker, Jackie Keane, Amy Tunney and Jane Layton. With regards to the introduction to the handbook functions and decision map, as you say, Chair, this is a standard set of documents. However, there are some further documents 4A down to 4F that will require approval from the board. And really, it's for any questions.
Are there any points anyone wants to raise on this matter? Okay, thank you very much indeed. Moving on then to item 4A, standing financial instructions and financial limits. And John Connolly, the ICB's Executive Director of Finance, is going to introduce this item.
Yeah, thank you. So we are required as an ICB to adopt standing financial instructions, or SFIs for short, and financial limits. The first part of this, the SFIs, they're the financial framework under which we operate and a key part of our control environment. There's some narrative in the paper as to why this is important, but I should say, although there's quite a lot of detail in here, this again is effectively a standard document based on a national template. It's been produced by a group led by a CCG CFO and supported by the governance leads of the CCGs. The main changes actually are in post titles. For
Is everybody content to approve that? Good, thank you very much. Moving on then to item 4B, which is the scheme of reservation and delegation. Claire.
Again, Chair, there's a common theme. It is a standard document, and it is something that we have to approve at today's board. It sets out responsibilities and functions, really what is reserved to our board, what is delegated through our committees or individuals. For approval from the board, please.
Okay, again, any comments or questions? Are you content to approve that? Thank you very much. I should have a gavel to bang after these things. I do miss that, but there we are. Then we move to the establishment of the board committee structure and appointment of committee chairs. And I'll ask Sam Allen, our Chief Executive, to cover this item. But just to say, first of all, this is very important, as many of you very experienced in boards. The subcommittees are a very important part of the business of the board, and so we gave a lot of consideration to how this should work. We had some guidance that we had to follow, but go ahead, Sam.
Thank you, Chair. Just in terms of this item, another item for approval by the board today, which is the establishment of the ICB board committees, of which in our operating model it is proposed that there are 5 committees: an audit and risk committee, a remuneration committee, an executive committee, a quality and safety committee, and a finance, performance and investment committee. Within the paper, there is a table that sets out the proposed chairing arrangements. 4 of these committees to be chaired by independent non-executive directors, with the executive committee chaired by myself. Also within there is the proposed membership and exemptions. Over the next week, we will be populating this with names and agreeing the names of the chairs of these committees, Chair. So this item is simply to approve the proposed board committee structure.
Any questions or comments about this one? Chair? No. Yes, please, go ahead, Ken.
It's a very small point, but it's important, I think, to get the terminology right from day one. We refer to audit and audit and risk. So the front paper confirms an audit committee. Can we just confirm it is audit risk, and that should flow through all the documentation consistently?
Okay.
That's right.
We'll make that adjustment. Thank you. Yes, please.
Is there a process for recruitment for the different subcommittees, or how will that look, just in terms of populating those meetings?
So in terms of populating the meetings with the membership, we'll be working that up with the corporate governance team over the next week, Tom, and we'll let you know about that. In terms of the membership, as detailed in the enclosure 4C, that sets out the proposed membership of that. These committees will be populated with executive members of the Integrated Care Board, and as I said, 4 of the 5 will be chaired by independent non-executive directors. What I would propose we do, Chair, is circulate the proposed membership to members of this board for information.
Okay, thank you very much. Right, and it looks like everybody's happy then to proceed with that structure. Then we move on to item 4D, which is a separate aspect, the terms of reference.
Yeah, so notwithstanding Ken's point, the terms of reference for the committees that we've just discussed are detailed within the papers. Again, many follow a standard template. They are in line with NHSE guidelines, and they've been developed in partnership across the North East and North Cumbria corporate governance colleagues.
Again, are you happy to agree to that? Good, thank you. Now the next item, 4E. There is a lot of detail in this, and so I'd like to just make a comment about the overall situation with these policy documents, which cover key and high-risk areas, strategies and policies. Now, it's necessary for us to adopt these, which are clinical commissioning group procedures and policies, in order to keep continuity of business. and services, actually, in some cases. But these have not been reviewed fully in an integrated care board context. And some of them I know that individual members would probably want to discuss in more detail. And there may be points which there's a need for adjustment. Some of them are a few years old and may need to be modernized and brought up to date. So what we would propose that if you're happy to agree that these should be agreed for the time being, that we would bring them back in modified form to a meeting in the near future, so that you have the opportunity not just to see the finished version, but also to discuss and debate any of them. And if I could also ask that if any members have an interest or comments to make about a particular policy in this list, that they would let us know, so that we have the opportunity to take on board your advice on how we should be proceeding. A classic example would be the serious incident management policy, where I think there have been changes in thinking both nationally and internationally about how this whole subject should be addressed, and we could benefit from looking at that through a more up-to-date lens, I think. But I'm very happy if you want to pick up any particular of these policies now and say anything or ask any questions about them. Okay, and you're happy with that way of handling it? Thank you. Just I should have just reminded everybody, if you do want to speak, just so that we can see, you do put your, it's the equivalent of the hands up sign on Teams, which is life imitating art, or vice versa, or whichever way you might want to put it. Thank you very much. Now, this is one of the, I think, let's put it, the more interesting papers on the agenda. The People and Communities Involvement and Engagement Framework, published in 2022. Claire, again, you're going to introduce this, please.
Yeah, thank you, Chair. And firstly, just to pay tribute to the engagement leads across the North East and North Cumbria engagement network under leadership with Julie Clayton, who now doesn't work for the NHS, but I think it's important that we pay tribute to their work and Julie's leadership as part of the development of the of a nationally required document that was nationally expected to come to our board today. It has been confirmed by NHS England that this is one of the best that they have seen to date as part of the integrated care system submissions. I think it sets the ambition and the drive and the motivation for what we want to be able to achieve as an integrated care board, but also for our integrated care system. Whilst there is still lots to be done, and lots of work to be done with partners, we've had some really good and helpful engagement across partners, including Healthwatch, and I know we have Healthwatch represented today. But I'm happy to answer any questions. I'm conscious people would have read the paper. I don't want to necessarily go through it page by page. But I'm really proud of the work that the team have been able to do in such a short period of time.
Thank you very much, Claire. David.
Thank you. Thanks to Claire and her colleagues for a document, and she mentioned the word proud, and I think she can be proud of that, because it is very, very, very comprehensive in how it sets out how the voice of the people, can be heard within the ICB place and everywhere in between. The intentions are very clear, Claire, and to be commended. But in these early days, during this transition period, could you perhaps give some thoughts as to how you might translate those very, very good intentions into practice and meaningfully engage with the wider public? Thank you.
Yeah.
Go ahead, Claire. Yeah,
Yeah.
and Jacqueline, you might want to say something from a strategy point of view, but go ahead first, Claire.
Yeah, thanks, David. I think it's important to recognise that there's still really excellent work happening at a place-based level, and some of the engagement leads that have been historically embedded in the clinical commissioning groups. have done a huge amount of work with voluntary sector organisations and communities over the years, and I think that's certainly something to build on, David. And it's recognition that we're not starting from a base of zero, and that's some of the things that are already documented in the plan is work that is happening really effectively in systems now. What we're doing is really looking at where else, what's next, and what will be new. And I think that is where working with partners like yourself, working with other voluntary sector organisations too, to make sure that we have an ongoing conversation and a constant dialogue around the health and care system with our population, and that is something that we need to do, and I think hopefully that sets the ambition there. But also it's recognition that we need to understand what people are saying about us, and making sure that we track that and work and making sure that as a health system we are visible in the communities that we serve, and also make sure that we reference or at least can demonstrate the impact that what we have heard has had on services. So it is early days. There are pockets that are happening across local communities now, but what we do have is a really great network internal to the system. We have really great connections with our partners, and I think in working together we'll be able to get to the right place.
And Jacqueline, you're going to be leading on the development of our first strategy. I just wondered if you wanted to say how this might fit into your thinking on that.
Certainly, thank you, Chair. So I think this engagement framework is really, really helpful. As many board members will know, integrated care boards are required to work with their integrated care partnerships to develop an integrated care strategy. Lots of integration there, is the title, by December 22. And I've agreed with Liam and Claire that we'll bring forward not only a process for developing that strategy to the first meeting of the Integrated Care Partnership later this month, but also specifically communications, engagement and co-production plan that will sit alongside the development of that strategy, so that from the get-go folks can see how they can get involved in the creation of this really key strategy for us as an integrated care system. So I look forward to having many opportunities to talk to people from across the patch about the very important business of what we should be seeing and prioritising in that strategy. Thanks, Chair.
Thank you. David, you want to come in again?
Just finally, thank you for those responses, and just assure the ICB that the network of 13 health watchers are ready, willing and able to support whatever you do in the interests of patients. We will do whatever we can to help you along your journey.
We have had some discussion internally about the concept of the ICB, Integrated Care Board, becoming known to the public, and traditionally organisations at this level are really a sort of black box that the public doesn't either know about or need to know much about. But we would like to think that we do have an interface with the public directly, in addition to obviously what's done through the important place-based services. But Claire, I don't know whether you want to say anything about that.
Yeah, I think it's clear, and we just need to look nationally at the public perception of the NHS. This is something that we need to be cognizant of, but it's also something that we've got fantastic services across our region, but we also know that we need to engage the public more in some of the strategic intent of the Integrated Care Board, and I think all of which could raise our the confidence in our ability to deliver what we need to deliver across the health and care system. So I think that would be the right thing to do.
Mike, just to put you on the spot a little bit, I mean, there's a huge amount of interest at the moment about primary care, and views being expressed that the public don't feel that they have the access they need, and yet primary care has been under a huge amount of pressure. I just wondered, and we've had a national report recently by Dr. Claire Fuller suggesting a new way that primary care might be developed, and we know that it's played such an important part in each of the places that we've been working with over the last year to set up the ICB. But I just wondered if you had any thoughts about the public and patient involvement in relation to primary care services.
Thanks, Liam. Thank you for putting me on the spot. Actually, it's an opportune question. I think I was discussing with David over lunch about the fact that I think it's really important that we bring patients into that conversation to explain the problem, but also try and come up with solutions. And I'm really pleased to see co-production mentioned so prominently in this bit of work. There's a bit of work that we're working on with the AHSN to look at ways to incorporate e-consultations, which are an electronic way of engaging with general practice in a co-produced way, and trying to figure out the best way to deliver co-production in the NHS. And I think yes, I would agree that this is an opportune moment to try and work with patients and patient group representatives.
Thank you very much indeed. Are there any other comments on this item? Yes, please, Neil.
Building on that point, each practice has patient representative groups that meet very regularly, either in person or virtually. I think one smart thing we could do as an ICB is to try and capture some of that, ensure that the lines of communication from frontline primary medical services can find that any issues can find their way to the board, and that's something that we can certainly work on and harness that really important group. And I know they are linked in with Health Watch as well.
Yeah. I mean, I've done quite a bit of... Yeah, sorry, Tom, go ahead.
Well, I was just going to add to that, really, just in terms of our role in remaining vigilant to who we're engaging with and how we're engaging with people as well, so that views are representative of our communities. Because I think there is a big risk that we speak to those who are able to speak back to us, and that becomes an exacerbation of inequalities. Ken's Trust, for example, is doing some fantastic work around health literacy, trying to understand how we reach out to communities that have lower levels of literacy than others, because fundamentally they can't engage if we communicate with them in the way that we've always done. So I guess it links back to this strategy and just making sure that we are always checking in that we've managed to get to representative populations rather than just speaking to lots of people, because actually we might be speaking to the wrong people.
Tom, and I think there's a real opportunity as part of the framework to spread and share best practice. And I know of the work that's being done around health literacy, and there's other pockets of work, lived experience, and making sure how do we weld that as a model within the work streams as they are developing or their plans or as things evolve. So there's some great opportunities, and there's certainly lots to do, but I think we've got a really good baseline to build on.
Sam?
Thank you, Chair. I just wanted to make the point around what may for some be a subtle change in language, but it's quite an important one, I think, particularly from an NHS perspective, where the paper and the strategy talks about citizens as well as patients. And I think one of the, and it very much picks up the point you were, I think, making as well, Tom, about we need to make sure that we are listening and engaging with all parts of our communities. And while some people will be very active in terms of healthcare or have lived experience or be under health services, the vast majority of our communities won't be. They won't be in active treatment. They won't necessarily have a long-term condition or chronic comorbidities, but their voice is absolutely equally important in terms of shaping health and care as citizens in our communities. So I really just wanted to kind of draw our attention to that point, which I think is quite a significant step change in some of these strategies that perhaps be more traditional from an NHS perspective.
Thank you. Rajesh, the mental health field, this is a big part of modern delivery of mental health services, but complex. Any thoughts on your experience, and is there more work to be done there to try and expand this involvement of patients and families?
Well, I think the first thing to say is that we are, for the maybe in my sort of professional career over the last 25 years or so in mental health, we've never been at a better place to really engage people who can drive their care. And partly, I mean, integration has been talked about, but partly there's been a number of national sort of policies. So I'll give you one example. You've talked about the Fuller report, which is looking at integrated primary care. But we've also got drives towards integrated community transformation. And I think that particular forum, which actually brings communities together to look at mental well-being and driving mental health care, which we can't do effectively unless we have people with lived experiences, communities, the voluntary sector, and all those who sometimes don't have a voice, especially those with addictions and other conditions. So I think we've got the building blocks. The biggest challenge now is to use this opportunity to draw on some of those opportunities we have to see how we can tease that out to make a significant impact. But I think we've got some good building blocks.
Thank you. John Rush.
I just wanted to say in terms of the resources that we have available to do engagement or co-production, don't underestimate what you do need or what we do need. And one of the things I would be really keen to sort of explore is between local authorities and the health service, how do we coalesce the resources that are available in terms of community engagement on an ongoing basis, because they do exist. And I think sometimes they're done a little bit separately, so that's one thing. And then the second thing is not to be frightened of early engagement with communities about any kind of change policies. In the past, I think we have been a little bit frightened from an NHS perspective and come up with options that suited what we thought, rather than kind of listening first of all to communities and what they think we could do. And the earlier engagement and the actual mechanisms that they can see and feel it, is you end up improving the trust and confidence of communities. And I think the trust and confidence of our communities is going to be one of the biggest things that we need to do, because communities will change as long as they understand what's happening and the reasons why. But I think that element can only be done by a lot of hard work and relevant resources being put in place to do it.
Okay, just before you sit down, John, there's been a lot of comment in the background to the establishment of the ICB that it needs to fit the different context of healthcare in a region as large as this. And obviously, one of the contrasts is between health and care and even health, population health in an urban environment and in a rural or semi-rural. And par excellence, Cumbria is in that category of rural and semi-rural. Northumberland, many other parts of the integrated care system geographical area as well. Is there, and when we think about public and patient involvement and engaging with communities, have you, in your experience, have they got concerns about access to care and consistency of care? But maybe you could say a few words about that.
Definitely, on both of them. And again, I suppose I have come from the North Cumbria region and I live in North Cumbria. I'm sure the same will be echoed across some of the other rural areas that we have. But the biggest issues are around how far is it to travel, and particularly around things that create potentially emergencies, such as maternity and where those locations are. And I know we spent a lot of time working out where we could provide relevant services in a geographically isolated area, and it's very, very contentious, but very, very important. But I go back to the point I said before. If we have ongoing engagement through whichever forum it is, we can introduce the fact that some of these changes are about to be made, or we are considering them, and then it doesn't come as a surprise. And I can't underestimate how important that is. But it's building the mechanisms and building the structures. And I go back to the other point is we've got to do that with local authorities. And we've got to do it with Health Watch as well, in terms of that connectivity. But it takes a lot of work, and it takes people who step forward into a space who are able to do that and create that personal, and I'm talking really personal connections with people, because it matters.
Thanks, John. Eileen.
Really, to add to this point about how do we understand lived experience and how do we reach out to all our communities, we have another community, and that's the community of people working in our universities and in our higher education organisations that have got a workforce that's skilled in understanding how we can reach out to people, how we can collect their views, how we can think about their priorities. So we have 19 National Institute for Health and Care research infrastructures, organisations that are about evidence, and about all of those infrastructures have a commitment and resources for public involvement and community engagement. And we've been doing this work, and the applied research collaboration itself, working with all 6 universities, we've got people who understand where our communities are, what their views are, what their lived experience is, and what their concerns might be about not only health but also well-being, and how to promote that for themselves and for their families. So in this spirit of partnership, there is a community that is also around us that is really, really wanting to step forward and be part of this conversation.
Okay, thank you. Mike, is your flag up?
It is.
Yeah.
So just to credit one element of the report, so page 21, I think one of the most important sentences in the entire report is setting the principle that, and an expectation that all business cases that come to this board will have evidence of involvement and engagement in both the preparation and implementation stages. And bearing in mind that I think a lot of the work that will be done in the region will be done below the level of this board, I think it's really positive that we're setting the tone in that way. I think for practical reasons it may not be possible at every level, but it definitely sets the expectation that where it is possible, it should be done.
Okay, thank you. David?
Thank you. It's very
just get
reassuring.
yourself a little bit closer to the microphone, if you wouldn't mind, David, just for the people online.
Certainly. It's very reassuring to hear so many positive comments made about engagement and involvement right across the board. That's great. But might there be a case from this board to set its example with the staff within the ICB? Because I'm sure within the ICB, the ICS, the ICP's place, or wherever, there are pockets of very, very good practice, particularly in terms of early engagement, which is critical. But perhaps there might be some areas within the organisation, vast as it is, where the message hasn't quite got through yet. So I'm just suggesting that the example which has been set very clearly by this board is somehow transmitted, and the importance of it, across the staff throughout the organisation. Difficult to do, but I think it's important that we would seek to do that. Thank you.
Thank you. I mean, I'll ask Claire at the end of the discussion just to come back, but I think the very important big point made here about that the connection isn't just with individual patients or patient groups and families, but with communities and neighbourhoods as well, which I'm sure. But Ken, you want to come in?
2 comments for me. One, this kind of whole concept of personalisation of our public services has got to run through, I think, everything that we do. We've got a unique opportunity here, the way we're structured regionally, but in some of our localities as well, to make sure that's glued better together. And the second comment to make is, don't also underestimate the impact of some of our foundation trusts that are well integrated into our communities. We have things like our Council of Governors and members, and some of our organisations have quite a substantial reach into our population. And I don't think we actually make enough of that as FTs. And I think if we can harness some of that, this will also help directly cement some of this agenda together.
Yeah, okay. Well, Ken, you're chair of the Provider Collaborative, so we look forward to working very closely with you on this. Thank you. Claire, no, but I think we haven't got any other comments. Annie, did you want to comment? Please do. And
it's just in relation to David's point about our people, really, David. And we took an early opportunity with our workforce to ask them to shape the values of the new organisation going forward. I'm delighted that they have been selected, but 2 of those values deeply ingrained around engagement and volume. So the first of those was respect, our commitment to listen to our communities in a respectful way, to pay attention to representation in the way that Tom referenced there. And the other one was around compassion, a core value for the organisation going forward. So I was really, really encouraged that, faced with an opportunity to select a number of values, that at least 2 of those will be deeply linked to the way that we engage and involve our communities going forward.
Jackie.
So I was just trying to think through what's going to be different and how would we improve it. And probably 2 things that come to mind. I think one is the issue about diversity and making sure that we talk to everybody, and in particular thinking about the priority that we've got around inequality. So how do we kind of reach out and think about some of the different groups? but also I was struck by some regional work that was undertaken post-COVID, particularly with young people and understanding their experiences. And actually when we talked to kind of, you know, children in school, mainstream school, they gave us one perspective, but actually when we dug deeper and in particular looked at children with additional needs, and particularly children, they gave us a very different perspective. So it's very important to think about that diversity and making sure that we capture that. And I think that the second thing that came to mind is really then, I think that a number of people have made the point that we have got lots of systems, and I think John's right about how we join that up. But I think that perhaps what would make it better is to have a consistent narrative in a language that not only we collectively understand, but probably more important, people understand in terms of the general public.
Okay, thank you. Eileen, you want to come in again? And I'm being asked to make sure that everybody, I know the mics are not dispersed everywhere, if you could pull it close towards you and pretend you're at the Stadium of Light.
Yeah. So the conversation so far has been really great, because I think in principle we are all absolutely, committed to this agenda. I think we need to get past principle and then into practice and what we're going to do. And I just really want to say we're not starting from scratch. So there has been an exercise called the Multiverse, where members of colleagues of mine have been out to 18 locations and spoken with 3,145 individuals across our region, asking them what's most important to them in terms of health and well-being. And we have a report from this multiverse work that the NIHR infrastructures have done that's already to inform you about what members of our public think is most important to them in this whole arena. So I think we've got a lot of building blocks to work from already, and we're not just at the beginning, we're actually some way through this journey, but having everybody aligned in terms of their commitment to the agenda is hugely important. And I just want to add to what Jackie says. Sometimes we don't always hear the voices of children and young people. It's important to do that one. And one piece of work that we're taking forward at the moment is some work from children who've experience of autism. They've designed their own piece of research work about inclusive schools for children with neurodiversity, and we're going to be supporting that over the next year. And we're funding 5 young peer researchers to help drive that work forward.
Thank you. I think that's a great example, although we're discussing a specific strategic area, a very important one. I think it's a great example of a point that quite a few people have been making over the period when we've been planning the new ICB, that in our universities we've got huge amounts of expertise and there's no map of it. And so I think we need to identify across all of our areas of service and care where the experts are, and often they will have done great work like that which we can immediately draw on, and that's something that hasn't happened particularly before. And I think the integration of our work with some areas of the university's work, and we've got some really great universities in the northeast and North Cumbria, and we can build on that. Thank you, Eileen, for that example. So Claire, I think we've come to the end of interventions from board members. You'd like to say anything in conclusion?
Just, I mean, it's really encouraging to have this conversation at our first board, actually, and hear the commitment that all partners have in this work. I think we're all excited by the opportunity. As Eileen says, we're not starting from a base of zero here. And I think our actions will speak louder than our words, and we have to focus on that and look forward to coming back to future boards to update everybody on where we are.
Okay, well, thank you very much for some very, very helpful insights and experiences, which, as Claire said, we will be coming back to you to talk about this again. And we move on now to item 5, and this is one for you, Sam.
Thank you, Chair. So this isn't very much another procedural item in terms of setting up the ICB as a new organisation. The paper sets out 10 specialist roles, lead roles that are required, and also the role of the appointed board member. With the exception of the mental health lead, however, I'm delighted that we do have Dr. Rajesh Nadkarni from one of our 2 mental health and learning disability organisations, and being a forensic consultant psychiatrist brings that particular expertise to our board, which is a statutory requirement. Notwithstanding, there will be other colleagues colleagues around the table who do also have experience of mental health and learning disability services too. There are 5 further roles that are not captured in the paper that were a specific request of NHS England. And Chair, what I would just like to do, given that they're not captured in the paper, is just read these out in full with the title of the person who will undertake them. The first one is an executive lead for children and young people, and that will be our chief nurse, David Purdue, who will also hold that role for the North East and North Yorkshire region. David will also be the executive lead for children and young people with special education needs and disabilities, and will also be the executive lead for safeguarding. And then just 2 final roles, an executive lead for learning disability and autism will be Mark Adams, one of our executive directors of Place, and the executive lead for Down syndrome will be Dr. Neil O'Brien, our medical director for the ICB. So what I would ask, Chair, is that the board approve the appointment, names of the appointed board members for the specialist lead roles required.
Is everybody happy to approve that? Thank you. And then the next item is also yours, Sam.
Thank you, Chair. So today as an integrated care board, we are meeting really against the backdrop of recovery from the COVID pandemic, but also seeing a 40-year high in terms of cost of living. And we know that this is already having an impact on our communities and indeed our health and care workforce, who are members of those communities too. And we're also seeing an increase, particularly in the number of families and children living in poverty. Having said that, from a North East, North Cumbria perspective, I do want to recognise the significant amount of work that has been undertaken over recent years, particularly on prevention, and that of Amanda Healy, who is our Director of Public Health in Durham, and Dr Guy Pilkington, a Newcastle GP, who have co-chaired our prevention board and have undertaken a number of prevention initiatives. And also the Chief Executive of one of our foundation trusts in North Tees, who has led a particular advisory group for health and equalities. I won't go through the paper in detail, Chair. However, what it does set out, though, is the very particular circumstances that we have here in the North East and North Cumbria, and particularly that of our communities. It is not...
Sam, sorry to interrupt your flow, and you must flow on, but you're on item 9.
I don't myself.
You've jumped ahead. So we carry on with this item now?
Can we do that, Chair? Is that okay?
Yeah.
Thank you. So in terms of the health inequalities, we know that they are not where they need to be for our communities. We know that life expectancy is still below the average life expectancy when we look at that for England. We also know that if you live in a deprived community in the North East, North Cumbria, your outcomes are going to be far worse than if you're living in a deprived community in the south of England as well. Putting it quite simply, Chair, we have some significant work to do. And one of the founding aims of all integrated care boards, we're one of 42 in England, is to address health inequalities in our communities. And therefore, what this paper on health inequalities and sustainability, which also picks up the work underway, particularly around the carbon reduction requirement, is making a recommendation that we establish a particular group over the next few weeks that would examine the work on health inequalities right across the North East and North Cumbria, and bring back some proposals, Chair, to this board in the autumn in terms of addressing the health inequalities and particularly really getting underneath the actions that we're going to be proposing that we take as an integrated care board.
Thank you very much, Sam. Well, I know that this is a subject all of us around the table feel very passionately about, and some of us, or some of you, are particular experts in this area. So it is a very preliminary look, taking stock of what has happened up to now and giving an outline of what might be done in the future. But there's a lot of work to be done, I think, to put flesh on the bones and to get this right. But we'll start off with you. Yes.
Yeah, thanks, Liam, and thanks, Sam.
I'm a bit closer to the microphone, if you
it
wouldn't
does
mind.
seem a little bit far away. Let me pull that a bit closer. Thanks. I just want to really welcome this report. I think it's. I think you're dead right, Sam. There's been some excellent work that's taken place over the last few years since we were required to come together as an integrated care system and work on the old STPs, if you remember those. Brought together a lot of work around health inequalities, and there's excellent work taking place right here, right now, in some of our place-based communities, really trying to get to the root cause of health inequalities rather than just health outcomes that we see in relation to health inequalities. So I think the timing's right for a stock take, and so we'd really support this piece of work. Not least because, as you reference, health inequalities is one of the kind of founding aims of the ICB, and that was one of the things that's really kind of drawn my attention with this reform, is that improving health outcomes is objective number one, and reducing health inequalities is objective number two. So part of my reflection is how do we hold ourselves to account here at this board around those two key objectives? How do we make sure that health inequalities is something that we look at for every single agenda item we discuss, whether that happens to be finance, performance, whether it's about our patient and public involvement? How do we make sure that we're constantly looking at these issues through a health inequalities lens? It was actually something I was going to raise under the delivery report, except we've gone slightly out of sync. But how do we, through our delivery report, look at health inequalities so that we don't just look at inequalities in outcomes, we look at inequalities in service delivery and service access and service outcomes as well. And I think that's something that I'd really like us to think about. It's a big challenge to look at it through data, but it's not impossible. It's arguably very possible. And how do we live by our principles, I guess, and demonstrate that through our leadership behaviours here at this board? So just welcome the report, welcome the stock take, and challenge us to think about how we make sure we're looking at everything through that health inequalities lens.
Thank you very much, Tom. Neil.
Yes, thanks. So again, I also welcome the report, and we have started some work on looking at this already. There are some well-established ICS work streams looking at this, and we're starting from quite a strong position. It feels like we have all the tools necessary to make some real inroads into this, but I do believe that some of the connections that need to be strong aren't there at the moment. But the examples with our universities and harnessing all that experience, we've got fantastic partnership working at place. How do we connect that across a larger area? So I think we have the bare bones of how we could pull all of this together, and what's the relationship between our work on health inequalities with our ICP arrangement. I think that needs to be worked through as well. So another partner to mention is NEX, North East Commissioning Support. They've got fantastic data resource that we've been working on for a number of years in a structured programme of population health management over the last 2 years. And those tools are there. They are within GP practices, but it's just making that final step to actually utilise the power of the data that we have to start making a difference and make some inroads into the health inequalities. So there's a real opportunity, and I think it's that, as you said at the beginning, it's about strong partnerships, and then that'll hopefully make a difference for people on the ground.
Thank you. Eileen, I know that you've already made some very important comments about the leadership role that you and this region has in the national research in health inequality, but could you possibly just give us, for those who are completely unfamiliar with it, a little potted summary of what this has to offer, if we are able to tap into some of the work that's being done, what this has to offer to the ICB's work on health inequalities?
Yeah, thank you, Liam. I'll start with the applied research collaboration that I direct links together the 6 universities in the North East and North Cumbria with all of our partners across the NHS, public health, social care, primary care and voluntary and community sector. We've actually got 58 organisations that are part of our ARC, with those universities. We were given national leadership in prevention and inequalities and just shy of £4 million to take forward work across region with other ARCs in other parts of England under the area of health and care inequalities and also prevention and looking at behavioural risk factors. Some of that work includes work around health and care systems as anchor organisations, as major employers in regions, and what difference that can make in terms of providing good jobs for people in this part of the population and what impact that might have on their well-being. We have, as an ARC, and we're a relatively new structure, 2 years old, a little bit older than an ICB, but over 2 years we've taken our direct award from just short of 9 million to 14. We've appointed just around about 50 2 or 4 year fellows to generate evidence on practical questions that are of priorities for our partners in the health and care system, working in partnership with practitioners and public members to take forward, generating evidence on some of these key areas of interest for us. But what we're also interested and focused on doing is mobilising evidence that we hold to try to help it bring forward to support decision making. And also we stand there with our skills in methods to think about how do we evaluate some of the decisions taken by a structure such as an ICB and its integrated care partnership, so that we know that the decisions we make and the changes that are enacted actually lead to the outcomes that we'd hope for people and patients. With that ARC, prevention and inequalities just transcends everything that we do. We have a lot of capacity and a lot of expertise in that area. There's been a lot of describing this problem, and now we need to really move forward and think about how do we actually generate solutions and interventions to address the problem. I look at Tom sitting next to me because Tom's been involved with us since the get-go. He's very much involved in our area around health inequalities and marginalised communities, and I wonder whether that part of the ARC might actually convene some meeting to maybe just bring together all the evidence that is at their fingertips, which is a deep understanding of inequalities, not just here, but in detail here, and also some of the work we're taking forward on tackling inequity in our region.
Thank you very much, Eileen. Anne Workman, pull the microphone a bit closer, because that one on that side seems a bit wonky.
Thank you, Liam, and thank you. I really welcome this report very much. What a fantastic opportunity we've got in terms of this, and just going back to Neil's point around place, our local areas, some of the cracking work that we've undertaken, our public health teams, the voluntary sector, the work we do together, the opportunity we're going to have in terms of place-based is incredible, building on what we've got already. And we talked earlier about people who are seldom heard. It's more around people who are seldom listened to. So it's getting that message across as well. So I just think it's so exciting. But thank you.
Thank you very much indeed. And John.
Mine's just a quick one about coordination and not duplicating things. You'll be aware, Liam, that obviously in Cumbria and Lancashire there was a Health Equity Commission that was initiated by the local authorities and the health partners, and as well it was sort of drawn together by Sir Michael Marmot. And it's just to say that whoever's doing this work for us needs to take cognizance of that work, because obviously the local authority were people that were very interested in it, so it's just to coordinate rather than ignore. I welcome, as everybody does, the work that we're talking about here.
Are there any other comments anyone would like to make? Oh, sorry, Isaac, go ahead, yes.
Thank you. Following on from Eileen's, where I'm really heartened to learn of all the fantastic work that's going on in the universities. And one of the things that I think would be really valuable for us as an ICB to work towards is we have ambitions to create a system which is constantly learning. And what we want to do is actually possibly take the research elements of learning more quickly into practice. And how do we create systems within our ICB that enable us to take that evidence that we're generating constantly from the great work that the ARC is doing into impactful service changes out there in the community?
Used to be called the knowing doing gap. It was a snappy way of describing it. Sarah, you have to pull your microphone a bit closer, I think. Thank you.
Thank you, Chair. So I was just thinking, in line of what we've been saying and tying
linked in with the previous discussion we had about people involvement and engagement. I think we can't look at health inequalities as just health inequalities. It has to be a seamless transition of what our citizens are telling us and that translating into how we will improve our health inequalities. So I think very much our previous discussion ties in with what we're discussing right now.
Okay, any other comments? Yes, please, David, go ahead.
Thank you. A cautionary but still positive comment. No one underestimates the importance of tackling the inequalities agenda. But within Northumberland, I think there will be 4 or 5 different organisations, partners, all tackling the inequality agenda. And I think one of the key tasks facing the board and everyone else is to coordinate the work which is being undertaken, because time, capacity, personnel is not unlimited. And I think to avoid duplication in this area is absolutely critical. Otherwise, many people could be working very, very hard towards the same end. And I think one aspect of life, work and health and care is to avoid duplication. And I think that is something we must be mindful of with the tremendous amount of work which is being undertaken to make sure that there is coordination. Difficult though that may be, I think it needs to be undertaken actually.
David.
Yes, thank you, Chair, and I would wholeheartedly agree with that comment.
The microphone, David, pull it a bit closer.
I would wholeheartedly agree with that comment in relation to this item, but also the engagement item. There's so much resource out there and so much capacity. We haven't got to try and do things again and duplicate, because that will just cause problems and frankly waste time. So really, if we get on and do that coordination piece, I think that would add real value to the system. So I think as a board we should stand by that.
Okay, thank you. I don't see any other requests to speak, so Sam, would you like to round this off?
Yeah, thank you, Chair. I mean, just to say thank you for everybody's comments on this. I think, Tom, your points around service delivery and outcomes are absolutely crucial, as well as challenging ourselves around our leadership behaviours. We have to be really clear about what our priorities are and therefore what the outcomes are and how we're measuring that and how we can track progress. I think the point about coordination absolutely gets to the heart of this paper, and the reason why doing a stock take will be important for us. Having said that, the comments about place are absolutely crucial. The founding of this work is at place, and we have many examples of work happening at place, whether it's in Northumberland, as you described, David, the Health Equity Commission in Cumbria, of which we are contributing to, or the Poverty Commission, for example, on North Tyneside. There is lots of work underway, and it isn't the role of the Integrated Care Board to seek to coordinate, to control that work, but what we do need to be clear about here are the things that we are going to focus on, what those priorities are and how we're going to measure what the impact of those will be on our communities. So, Chair, take the broad support today to set up this group. We will certainly keep the board appraised of progress with this and look to bring the outcomes of this back to the board in the autumn. And what we won't be seeking to do is replicate any work that's underway, but also building on the expertise out there, and particularly the expertise that Professor Kainer described that sits within our universities.
Thank you very much indeed for that item, and also for the interventions and discussion, which are incredibly helpful to us. Can we now go back to where we were, Sam, before you jumped 3 items and deal with item 6?
So I was so keen to get into the health and equality
Yes, of course,
discussion.
I understand the passion. But
thank
bureaucracy
you,
is important too.
So this item is about the appointment of the founder board member of the Integrated Care Partnership, which is indeed yourself, Salim, the paper sets out. As Salim described at the beginning of our meeting, we have an Integrated Care Board and we also have an Integrated Care Partnership, which is made up of our constituent places, our 13 places across the North East and North Cumbria. And we would certainly be expecting involvement from the chairs of the health and wellbeing boards and each of the There are in fact 12 health and wellbeing boards across the 13 places, because a couple of places collaborate together through that. We do have to set out a founding member, so it is proposed that that is Salim. Having said that, over the weeks ahead we will be building the membership of the Integrated Care Partnership, and the Integrated Care Partnership will absolutely have a core role in setting our strategy for the next 5 years, which would seek to address inequalities, look to address the particular needs of our population, those wider social and economic determinants of health, and the aim really being to improve the overall health and well-being and preventing ill health and premature mortality. That real holistic view of what the public's needs are, our citizens' needs and our patients' needs are, right across the North East and North Cumbria. So the paper not only puts a proposal forward to agree the founding member being Salim, but it is a reminder of the role of the Integrated Care Partnership and indeed the Integrated Care Strategy that we will be developing over the months ahead.
Thank you. And just to be clear, that this isn't a proposal that I chair both boards. It's just something that's necessary to be a convener of a discussion. And there's a lot of flexibility in how the Integrated Care Partnership Board will operate. The preference at the moment for the health and local authority partners through the joint management executive group that's helped to develop a lot of the work for the ICB, their preference is that we would have one large Integrated Care Partnership Board and 4 smaller ones, which would work on a more day-to-day or week-to-week basis, with the larger one perhaps being too big to be sensitive to local needs, to be the only board. Obviously, some of the smaller integrated care systems around the country would only have one integrated care partnership. But the thinking at the moment is that we should distribute closer to local populations elements of the integrated care partnership. That can change. It's all really open to discussion, and we'll be doing that over the next couple of months. Now, if any members of the board would like to be more directly involved in any of the work or the thinking, just let us know, and you'd be very welcome to participate. Otherwise, is everybody happy with that proposal? Okay, thank you. Well, the next 2 items are deal with the profile that we've inherited. As you know, we have not been accountable for the performance of the NHS in the last year or 2. When the integrated care system came into force, it was not even a shadow organisation. It was helping and facilitating partnership working. But in the course of that, of course, had a good understanding of the performance of the system, particularly and notably during the COVID pandemic. But the accountability was not in place, but it now is in place. So we want to let you have an insight into the performance profile and the financial profile that we have inherited and that we are all from now on accountable for. So if we could start off with item 7, which Jacqueline's going to take us through.
Thank you, Chair. So you have in your pack an integrated delivery report, which runs to, I think, 37...
The microphone a bit closer, Jacqueline.
So, which I think runs to 37 slides. And important though this report is, I don't propose to try and do those 37 slides individual justice. Rather, I'm just going to take you through a summary, and then obviously there'll be opportunity to ask any questions. But before we start that, I just wanted to make a couple of remarks about the integrated delivery report. I'd like to thank the many CCG colleagues who've worked on pulling this report together for us so that we can go through it this afternoon, but in particular Siobhan Brown and Claire Dovell. I'd just like to say 3 things, I think, about the report. obviously, as Liam has framed for us, it's an introduction to how things stand across the ICS rather, as we take up the reins this afternoon. But I think that in future meetings, it will sit in a kind of more organised structure of oversight, assurance, escalation and improvement support. So I would expect that in future that the detail that you see in the report here, and in fact more detail, will have been scrutinised and discussed in our quality and our finance and performance subcommittees, and will have the benefit of chair reports and insight that's been gleaned in those meetings. The second thing I wanted to say was about the place that the report will have in our kind of wider arrangement. So I would expect that we would hope to see a sort of golden thread from the strategy we set to the one-year plan and the milestones that we wish to achieve over the year, and use this report not just to give us an absolute measure of how we're performing against various national standards and asks, but also to see whether we're delivering, as expected, progress that we've set out in our plan for the year. And so it would kind of sit in that framework. And the third thing I wanted to say actually speaks to the remarks that my colleague Tom made earlier, which is I think there's further work to do, and we've had some very positive discussions about this already, about how we make sure that the plan is giving us true insight and intelligence about the state of our services and how they're progressing. You mentioned, Tom, threading health inequalities throughout the report. And indeed, I think another lens is need, isn't it? Just yesterday, I was having a conversation with colleagues about the urgent and emergency care dashboard that's being developed, and how we must be really thoughtful about the measures that we're taking and the inferences that we're drawing from that. So an example might be where we see elevating levels of demand for urgent care. If that's not set in any kind of context in relation to the need in the population that those services are provided to, then we might jump to some erroneous conclusions. So there's plenty of work to do, I think, to continue to hone this report and make it as useful as possible to us as board members in understanding how our services are doing. So that's all I wanted to say, Chair, by way of introduction. So now I'm just going to take us through a limited number of slides, and then obviously there'll be an opportunity to ask any questions. So this first slide just sets out, in terms of the NHS and ICS priorities for 22-23, that we're not today providing you with a report against those priorities. They're set there in the bullet points, but we're aiming to bring that to you in the next meeting in September. This slide also notes that the NHS SOF, System Oversight Framework, was published just 4 days ago, so we just received that. And in the slides, I've outlined the position in terms of our providers and their ratings in the current System Oversight Framework measurements, which will be refreshed monthly as we go through the year. I would say in relation to SOF that it is very much focused on our larger providers, but as we develop our oversight framework for the ICB, we will obviously be looking at the provision of all services in addition to our larger providers. Okay, I'll just push on. So this slide just sets out the current SOF segmentation for the Trust. There are 4 segments set out in the National System Oversight Framework from 1 through to 4. We don't have any trusts in segment 4. Trusts that are seen as being in segment 4 are requiring the highest level of support and are subject to national support and intervention. As you'll see from the slide, we have 3 trusts in segment 1, we have 5 trusts in segment 2, and then we have 3 trusts in segment 3. In terms of the ICB's oversight framework, that's something that is currently in development and finalisation, and we'll be bringing that back to a future meeting. And we'll be working with our colleagues in NHS England around the implementation of that framework and how we support our organisations who are subject to the system oversight framework to improve their performance over time. This is a very busy slide. I hope you're able to have the opportunity to have a look at it in your pack, and it's really here by way of example of the sorts of measurements that we're starting to put together in the field of health inequalities. I think we're all kind of trying to... I'm just going to draw out a couple of examples of what's in here. And I should have said earlier, and I'd like to say throughout this, that we welcome feedback on the development of this report and whether board members find it helpful, if there is anything different you'd like to see or more, and we'll continue to develop it. But you'll see here, for example, we're looking at smoking prevalence in the middle column. And what we're looking at is over a period of 5 years, whether smoking prevalence the gap in whether smoking prevalence is getting better or worse, and it's getting better in the sense that it's lower. And you can also see that there's a slight reduction in the if you like gap between the highest levels of smoking prevalence and the lowest in our various places. In the circled area below, which is depression prevalence, unfortunately we're seeing not a good picture here, in that we're seeing higher prevalence of depression and a slight widening of inequalities there in terms of the gap between the areas that are suffering the most versus the least depression. This is in an early stage of development, so it's really just shared with you to give you an example of the sorts of things that we're starting to measure. And in bold there at the bottom, to remind me to mention to you, there is a national strategy around tackling health inequalities, which is called it's got a very snappy title, the Core 20 +5. And for the uninitiated, that's about looking at the 20% of our population who are suffering the worst health inequalities and really focusing in on how we support and deliver improvement for those populations. In addition, the +5 are 5 areas of local focus that we choose to identify for North East and North Cumbria and work on. So more, I'm sure, on our health inequalities approach in future meetings. This is a real summary slide of some of the quality improvement work and quality oversight work that's going on in the system. Again, just to reference you back to the larger pack where you've got more detail on the quality slides. So just to draw out some key highlights, or perhaps issues would be a better turn of phrase. We do know that we've got some significant workforce pressures across both primary and secondary care, and that is giving us some challenges. In particular, we've seen some repeated spikes in absence rates, which are relatively high for England, a lot of that driven by the COVID-19 pandemic, as people be aware. We have seen some issues in terms of our staff survey results that were published in March 22, where some trusts were below the national averages, and all of those individual trusts have action plans looking at how they tackle the issues that were raised in their staff surveys, but we do also have 5 trusts. So I've got that note in a row. I think it's 4. That's right. So we've got 4 trusts below average for recommending the trust as a place where relatives should be cared for, and then 5 trusts in terms of recommending the trust as a place to work. So obviously some areas for action by our providers there. In the pack, there is a detailed slide on the actions that have been identified for maternity services in the Ockenden review, and you can see some details about the progress that's been delivered by the individual providers there. This is just a slide drawing out some of the issues around primary care. These are slides looking at primary care activity levels. In the 2 diagrams, you've got first of all, on the left-hand side, a trend rate in terms of DNAs, that means do not attends, so patients failing to attend their appointment, which is obviously an area of concern given the pressure in primary care. The second slide looks at the provision of face-to-face appointments, and in the bullet points you can see that in April 22, 67% of all appointments were delivered face-to-face across our region. We've got a single data point in the narrative there just to give you a sense of scale of primary care in our patch. So 1.2 million appointments delivered in primary care just during April 22, and demand remains high. This is a slide looking at performance against the national accident emergency standard, that patients should be seen and either treated, treated and then discharged or admitted within 4 hours. This is the May 22 performance. You can see there that we do have significant and fairly enduring reduction in delivery against the 95% target. For May, we delivered 78% against the 95% standard. In North East and North Cumbria. The national performance was 73%, so relatively speaking, we are a strong performer, but obviously this is an issue which is causing concern, rightly so, nationally. We also have a diagram there showing you the increasing pressure around trolley weights, so these are patients who waiting to be admitted to a bed in A&E departments, and you can see in 22 since Christmas we've seen a real rise, and that reflects some of the significant pressures we've got on our bed capacity across the region. Again, this is not an outlier nationally, but that's not to say that we're not extremely concerned about it, and I know there's a lot of intensive work going on in our places looking at how providers can work together to try and improve flow through our hospital beds. And indeed, many schemes looking at alternatives to admission. And you've got a little bit of narrative here on the slide about what's going on in our 4 ICP areas. I'm just conscious of time, so forgive me if I'm not getting into lots of detail. This is a slide looking at ambulance handovers and also ambulance response times during the month of May. Again, this is just a flavour of the sorts of things that we're measuring. So you've got data here for both NWAS and for NIAS. Overall, as a patch, we are doing well on the C1 standard. That's the most urgent ambulance response standard of 7 minutes, but less well on some of the category 2, 3 and 4. There's a little bit of detail here about some of the work that's going on to address that, for example, the recruitment of additional paramedics, clinical care assistants and so on. And this is something that we're working very tensely on, both with our ambulance providers in terms of the response times and handovers, but also with the wider system, as clearly these are issues that need a multi-partner action to address. This is a slide on performance exceptions relating to RTT. Apologies for the acronym for the uninitiated. This is the 18-week referral to treatment standard that's been in place for many years as part of the NHS Constitution. For context, I think most board members will know that in more recent times, unfortunately, we've been in the arena of measuring 52-week, 78-week and 104-week waiters on a journey back to trying to get closer to the original target of 18 weeks. So this year in the operating plan guidance, we were set targets in relation to those waiting times, and these slides show you progress against those. So first of all, to draw out the good news, waiting times are falling across our region, which is good to see. Nationally, the ask was that there would be no patients waiting 104 weeks, which is 2 years and a very long time to wait, by the end of June, so yesterday. We have been aware for some months that whilst progress overall has been excellent, there are a small cohort of patients, mainly those requiring complex spinal operations, who we didn't have a solution for by the end of June. This is a national problem, and we are working with the national network and with the NHS England to find solutions for those patients, including offering them the opportunity to travel elsewhere for treatment. So we're still working through that. In the slide, you've got a little bit of detail about where we are in terms of delivering the 78 so just to be clear, the target is to reduce 78-week waiters to 0 by the end of March, and the progress against that, and to see a reduction, which we were able to define locally, in the people waiting over a year. We have been seeing reductions just in recent weeks. We've seen that start to move up a bit. It's not totally unexpected in that it's the kind of 1-year anniversary of referrals really recovering following the contraction of referrals into secondary care during the pandemic. So more patients were referred a year ago, and so we're seeing many more patients cross the line into the 1-year wait just now. But the providers have got plans in place to deliver a set of trajectories, and we're still aiming to deliver those by the end of March. This is an section report relating to this cancer standards. A few different standards covered here. Again, some really good news in terms of the faster diagnosis standard. That standard aims to see that 75% of patients get their diagnosis within 28 days of referral. Locally, our Cancer Alliance has set a stretch target of 80%, and currently we're delivering 76% across the region, which is really great to see. Where we've got more of a challenge is on what we call the 62-day pathway, which is another referral to treatment target, so 62 days from referral to treatment or diagnosis and discharge. And we have a backlog of patients who have gone beyond 62 days and unfortunately have not yet had either their diagnosis or, if they've got a diagnosis of cancer, their treatment. We have recovery plans in place to try and make sure that this is recovered during year, but at the moment we are unfortunately not in a position to be clear that we can deliver the national ask by the end of the year. Some really good work going on in that area. For example, one of the greatest areas of pressure is in the lower gastrointestinal pathway, and we've formed an endoscopy network to look at how the trust can work together to speed up the diagnosis of the patients on that pathway. This is, again, apologies, a very busy slide, just looking at some of the exception reports around mental health and learning disabilities and autism. There's a large number of targets referred to here in the slides. What we're seeing in real summary in relation to a number of targets is here. Most of these targets relate to increasing the number of patient contacts and treatments in order to meet demand. And although we have plans and we are seeing increased capacity and increased numbers of treatments and assessments taking place, we haven't yet got plans that get us to the level of activity that's set out in the national ask. So through the national programme, we've been set a set of numeric targets in terms of the volumes of assessments and treatments that we deliver in each of these areas. And I'll say a little bit more about that when we look at the plan slides. So a number of exceptions here and quite a lot of work to do with and across the sector to see what more we can do to develop capacity and workforce is one of a number of pressures in this area. Okay, so that is the whistle-stop tour of the very detailed performance and delivery report before you. Happy to take any questions, Chair.
Okay, I'd like to suggest we've been running for an hour and a half now, that we have a 20-minute break, and then we'll come back and have discussion on Jacqueline's presentation, and also then move on to the finance presentation. Is everybody happy about that?
Okay.
Okay, then, so we're 2:05, so we'll come back at 25 past.
Thank you.
Well, welcome back, everybody. We'll open it up now to questions and comments on Jacqueline's presentation. Mark, you were first. In fact, you had yours to hand up before the tea break, so go ahead.
Thanks very much, Chair. It was just to say it's really welcome to see this report at our first meeting, and I know it's work in progress, but absolutely congratulations to Jacqueline, Siobhan, Claire and colleagues to get it to this point. It was just to make the point, though, that we have a lot of representation of different organisations and groups around the table. And I know that the report is work in progress, but I also think there's a real opportunity as time goes on for us to think about other data sets, other sets of information that allow us to add richness and colour to the report as we go on. And I'm also thinking particularly here in terms of the conversation that we had earlier in the meeting about the voice of citizens. And the opportunity that we've got through the strategy that we spoke about earlier on in the meeting to be able to get more of that information from the voice of the citizens into the report about context, but also things that are going well, but also helping us to identify issues of concern going forward as well.
Okay, thank you very much, Mark. Neil.
Yes, thanks. I just wanted to make a couple of points. First is regarding the primary care data. I think it's worth recognising that the amount of activity through the pandemic and indeed to date, and the amount of face-to-face consultations that have continued throughout the pandemic, with all the negative press that was around there at the time, is probably worth recognition. And I think also that we need to also recognise that primary care have delivered 70% of the millions of vaccinations that have gone on over the last few months. The other thing to also recognise is that there's some challenging aspects of performance in here. I think that's fair to say, and no one who works in the NHS will be happy with this. But I think it's just to recognise our people and where they are. I think the staff have had an exhausting 2 to 3 years, and supporting our staff to make the changes to the performance is something that we should really look to focus on. And COVID has not gone away. I was on a call this morning. Staff absences are increasing. and the number of COVID cases are also increasing. So as we look to improve the performance of our NHS services, it just needs to be on that backdrop. So I just thought they were important points to make.
Okay, thank you, Jackie.
Again, a couple of points. I mean, Mark Storm.
Come a bit closer, please, Jackie, to the microphone.
Sorry, is that better?
Yes.
Okay. So Mark's stolen a bit of my thunder, but probably I think that in terms of this report, it's really comprehensive and it's really useful in terms of giving particularly an NHS perspective. And I think that for me, kind of moving forward, there's something about kind of how we look at the social care data, because equally there are some system issues that we need to understand in the context of the NHS data. And I think that the second point is then probably just in terms of then how we interpret all of the data and the analysis that sits behind it. And again, I would urge that we try to look at that from not only just an NHS lens, but a care lens as well, so we really understand what the data is saying, the impact, and we have kind of, again, a joint, consistent narrative around that.
Thank you very much. Mike.
Just to echo the points that this is an excellent report and an excellent start, I think, given the challenges of pulling it together from lots of different organisations. Just a few points to raise. Firstly, echoing Tom's point made earlier regarding inequalities. It's great to see within the outcomes section the inequalities highlighted over the years and whether the gaps are getting bigger or smaller. But within other areas of the report, there isn't a lot of reference to inequalities specifically, so I think there's definitely an opportunity there to focus more on that. The other thing that I noticed, and something I think we should be maybe paying as much attention to or more attention to, is the patient and staff experience indicators. There are some of those for the different foundation trusts, and there's quite a tight correlation between the trusts that need additional support and those where, for example, staff are saying that they're having a good experience or that they would recommend those places for care. Some of those soft indicators are a really good canary in the coal mine, so to speak, about what's going right and what's not going so well. And finally, just to point around the choice of indicators, I think the choice of indicators is really important because that'll dictate what strategies emerge from this data. And I think that's where we need to be bringing in patient perspectives and citizen perspectives wherever possible to try and make sure that we're choosing the things that matter to people.
Thank you very much, Mike. Sam.
Thank you, Chair. Just three quick comments. Elective recovery and recovery of waiting times for elective procedures in hospitals. I do want to acknowledge and thank our colleagues in our NHS Foundation Trust, particularly for the collaboration that they have shown in really wanting to drive down those waiting times and offer people across our communities the opportunity to have their elective procedure in one of those hospital-based services. And I would really commend that collaboration, and to also say that we would really like to see more of that as well, particularly in ensuring that we are offering that choice to our patients, but also we're reducing the waiting times. The second thing is I was really struck by the depression prevalence, and I was looking at the slide and seeing actually we've got an downward trend in terms of performance against that. However, within our 13 places, the best performing area, Newcastle and Gateshead, the least performing area, North Cumbria, two different populations, rural, urban, and I think that's a good example of things we need to explore and look at in more detail. And then just finally, I really again want to commend our primary care colleagues. 67% of all appointments seen face-to-face, 67%. During that period, but also against a backdrop of 5% of all appointments being people who have not attended as well. So we do know that one of the pieces of feedback we are getting, this is very much national, that more people do want to see their GPs or their primary care practitioners face-to-face. But it was good to note there that 67% of all appointments have been face-to-face over the last month.
Okay, thank you. Come in again, Mike.
Just to follow that from a primary care perspective, I would say that GPs, for the most part, also want to see their patients face-to-face. It's a two-way street. It makes it much nicer seeing a person face-to-face. Just a point on the DNAs within general practice as well. There seems to be quite a tight correlation between the face-to-face appointments and the DNAs occurring, which is not entirely surprising. And I suspect those two data points are correlated because of the way that IT systems work, so that there may need to be a little bit of scrutiny of that as to how reliable the DNA data is.
Okay, thank you. No other comments? Oh, yes, sorry, yes, go ahead.
Thanks, Liam. Just when we were talking about DNAs, I think the points referenced earlier about health inequality, I think DNA is probably a perfect example of what I'm talking about. If we were to look at DNA rates by deprivation quintile, for example, we would see wide variation. I'll bet John's £6.5 billion that we would see that gradient within the DNA rate. So it's an example of where we see intervention-driven inequalities, and that would be really key to include in the performance report moving forward. So I'm really keen to work with you on that, Jacqueline, if that's okay. And then the other thing was just about workforce. Workforce is such an important challenge that we're facing at this point in time, and I know it's referenced in the report, but I didn't know whether there were any kind of system-wide measures or indeed measures at different places that start to illustrate that, and something that we might want to consider including within a performance report, just given the significant challenges we seem to be facing across all workforce sectors at this point in time.
Can I just perhaps pick up with you and Neil? I saw on the news last night a health foundation, which one of our think tanks, of course, forecasting quite a big shortfall in general practitioners over the next 5 to 6 years. Is that going to play out differently in different parts of the country, or is it likely to be an across-the-board change, do you think?
Some of the figures that I've seen about general practitioners per 1,000 population, actually the North East performs pretty well nationally on that. That being said, we do have, looking at the profile of the workforce, we do have quite a number who are nearing retirement age, and quite a number of people who are actually retiring earlier because of the pressures of the job. That being said, there are quite a lot of doctors in training within this area. The new Sunderland Medical School as well will bring on a lot more doctors within this patch, and the training is actually more tailored towards a career in general practice. So we do have some initiatives that might help mitigate some of that, but undoubtedly it will be a pressure. And we need to work with our partners in Health Education England just to try and do the very difficult task of workforce planning in this group. It is quite difficult to do. Also, a lot of GPs now are looking at more portfolio careers and don't go full-time into general practice. But what we can demonstrate in this area that our practices in the North East and North Cumbria have been innovative in the workforce that they have within practices, so using nurse practitioners, pharmacists, and the extended roles scheme for PCNs has particularly helped with that. So in short, yes, there will be pressures. I think we're in a good place in the North East and North Cumbria, but it is something that needs to be carefully watched. And also, again, going back to the health inequalities, although the overall number of GPs per 1,000 registered population is quite favourable, there are pockets within the North East and North Cumbria which are usually more deprived areas that doctors, if they can choose where they work, don't tend to choose to work there for lots of different reasons. And that's something, again, we can look at as an ICB about how do we encourage doctors to work in our more deprived communities and under-doctored areas.
Mike.
Neil stole my comments. I was particularly going to emphasise the fact that the medical schools in the North East are very tailored towards community practice and general practice in particular, and have far more general practitioners come out of their training than other universities in the country. and training people locally tends to encourage them to stay local to the northeast. Myself being an example, but I have many friends from medical school who are GPs in the northeast now. So I think embracing the opportunity with Sunderland Medical School in particular is one opportunity area, albeit it's not going to pay dividends for a long time.
Okay, thank you. Right, anybody? Oh, Annie, yes, please.
Yeah, it was just in relation to Tom's query about workforce. So certainly the evidence would suggest there are a number of key metrics that we could look at. Michael West's research reminding us that staff engagement as a measure, the number one predictor of organisational outcomes. So something that we could certainly track and have an ambition. I think it's recognising as an organisation we would want to have a much greater ambition than an annual staff survey in terms of understanding the emotions of our staff, and have already taken early steps in a period of transition to understand where our own colleagues were feeling across all CCGs and in partner organisations like NEX. And with fantastic engagement, we have an opportunity to look at that data from the perspective of groups represented by protected characteristics and really understand variation in our workforce and what that means. And that provides the opportunity to work in partnership with universities around the use of technology and how we engage people in different ways and exciting ways for the future. So all things that we would hold very dear, not only for in the development of a new organisation, but also what we'd want to see across the system in terms of workforce and metrics relating to that.
Thank you. Sarah, did you comment?
Thank you, Chair. It was just to say that Sunderland has the sixth youngest GP workforce in the country, and that obviously if there are lessons to be learnt and shared, I think when we now have the mechanisms to do that, and I think it would be worthwhile to help understand our regional needs better and how we can improve under-doctored areas throughout our region.
Thank you very much. Yes, Eileen.
It was really to follow up about workforce. Can you hear that? Yeah.
Yes.
And apart from training, we need to retain people, and we need to make good jobs for our practitioners. You know, one of the things that we've been trying to do at the moment, particularly through the Applied Research Collaboration, is to provide opportunities for practitioners to take some funded time out of practice to develop their ideas around questions that they want to generate or qualifications that they'd like to achieve. It was a very super subscribed opportunity. We've just onboarded 16 practitioners who will take between 1 day and 2.5 days, fully paid, so they're backfilled, to be able to pursue qualifications or work with colleagues in universities to drive questions from their practice that they want to answer. So, and we are hearing that this is an element of attractiveness in a job, to have that space for time and thought to generate evidence around your practice and to build new skills, to become more evidence-informed practitioners.
I mean, sticking with the medical workforce, looking back on my longish career, it's been very noticeable the way that doctors who are starting on their training split between hospital practice and general practice. Certainly when I qualified, everybody wanted to go into hospital practice and no one into general practice. And then subsequently there was a big swing towards general practice, and particularly in Northumbria, where people like Donald Irwin, there were a lot of leaders who set up very good vocational training schemes and then there was another swing back in the 1990s towards hospital medicine. So that's part of the equation that isn't perhaps talked about as much, that you've got a cohort of medical graduates. Which way do they go? And there are all sorts of factors that influence that, to do with perceptions of what life is like. So if you know, getting too much gloom and doom about pressures, it has an immediate impact on then people's choice of career. Plus the fact that, having been involved in workforce planning in the past with the hospital specialties, it's almost impossible to determine the number of people that you will need in a particular specialty. There are 53 specialties of medicine in 10 years' time, which is the length of time it takes to train. And, you know, whole specialties sometimes wiped out by interventional techniques that mean that you don't need surgery for that anymore. So it's a very, very difficult area, and Annie will be, and you've got postgraduate deans and people of that involvement as well. Yeah. Okay, so Jack, where I can't see the flag. Oh, yes, Claire. Some of them look like water glasses, those flags. Go ahead, yeah.
Sorry, Chairman. It's just to pick up the point regarding recruitment, and it's a reminder that we have worked in collaboration with Health Education North East for some years regarding the NHS Find Your Place campaign, which really focuses on attracting junior doctors into the region into specialty positions and including into GP training positions. And there's probably more we can do to revitalise that and to really look at how we target that further to get the junior doctors into the area, but also looking to see how we use that model to underpin some of the recruitment effort to get more GPs into the area too, because we can cleverly use some of the algorithms available to us via social media to be able to be quite targeted in that.
Yeah, thank you. Yes, Rajesh.
Thanks, Chair. Oops. Can you hear me?
Go a little bit closer, and that's good. Thank you.
Yeah, okay. Just two quick comments. I mean, the first thing, just your reflection about how things change with the example you gave with hospital doctors coming in and that in general practice. Currently, the trend we are having is that if you look at the fill rates, post-medical school for psychiatry, we're having 100% fill rates. So clearly there's something happening where young people are very, very interested in mental health. But it will take a few years for that to kind of translate into kind of more specialist jobs. But the other point I wanted to make was, if you look at the mental health work stream of the ICS, the workforce group there has adopted a strategy. Clearly retention is absolutely important, making jobs which are doable, but more importantly also having the time to learn and think, because people have just lost the ability to do that because of what's happened over the last 2 years. But the work stream has looked at 3 areas. One is how can we support traditional roles with some new roles, and we talk about clinical assistants and so on, and then also how can we look at new roles which are outside of the traditional roles, people with lived experiences and so on and so forth. And then look at how can all that be linked together along with the retention aspects. So I'm just wondering, Annie, as we look at examples, I mean, there are great examples all over our region of what people are doing, foundation trusts, local authorities, VCSCs and so on. But it might be useful to get that approach and see whether we might want to make a statement as an ICB around this and to see where we can add value to what is already going at many of the places or at trust levels.
Yeah.
Thank you.
I mean, you could certainly make rapid changes on recruitment. I was talking to the Chief Executive of South Tees Foundation Trust, James Cook Foundation Trust, and they were in the doldrums as far as covering quite a few key specialties. They just couldn't recruit people. Even locums are having difficulties, and apparently they have relatively recently appointed 90 new consultants. So you can do it. And I asked why. How have you done it? And it did sound a bit vague, but basically it was to do with making the culture and the mood and the feeling of development and change, giving that a very high profile, and it sort of worked its way through, and people wanted to come. So I think that's often a good feature of the North East anyway, and Cumbria, but it's something that I think we can build on. Yes, please, Graham.
Thank you, Chairman. It's really just a plea, because obviously we've got major pressures on clinical and allied health professional staff, but as we become increasingly dependent on technology, there's a risk and a challenge going forward how we attract and retain people in digital careers and data science careers. So again, those metrics apply to a whole range of our workforce colleagues that we want to make the North East and North Cumbria the best place in the country to work in a whole range of disciplines and specialities.
Thanks, Graham. Jackie, did you want to come in?
Yes. I think, I suppose some of the kind of things that people have put forward, particularly around clinicians and GPs and nursing, is really, really important. And I think we've had those issues for a number of years. I think that probably what feels really acute from a local authority perspective at the moment is particularly at the other end of the spectrum and thinking about carers, but also kind of home care and nursing homes, where there are big recruitment issues and basically nobody's stepping forward to kind of undertake some of that work. So again, kind of perhaps working with Jackie to try and just understand exactly the size of that issue, but also the impact, because clearly if that's not there, then that has implications across the whole of the system.
Okay, thank you. I don't see any other interventions. So, Jacqueline, you don't have to respond to every point, but just some general points you want to make?
Thank you, Chair. I won't attempt to respond to every point, but it's been a really rich and useful introductory discussion to what is a critical but complex thing to get right, isn't it? How do we measure whether we're delivering the outcomes that we aim to deliver for our patients, and how do we measure all of those key enabling processes that move us towards the outcomes we eventually want to achieve? So just a couple of things, if I may. It's very much my intention to set up a working group, a steering group, to get this report right as quickly as we can, but also to recognise that it will be iterated and developed over time. And also just wanted to draw out the obvious key link between developing our strategy and then reflecting a set of measures that relate directly to the priorities and objectives we set ourselves as a board and as a community as a result of that strategy. But I think in parallel to that strategy development work, which will go on for the months through to the end of the year, some of the areas that have already been highlighted today, this isn't an exhaustive list, but around health inequalities, around workforce, and around the wider health and care sector, we can concurrently be developing data streams and intelligence and insight in those areas, because we know they're going to be areas of focus in our strategy. There's also a key bit of work to do around data quality, completeness, so that our measures are robust and reliable, as well as being appropriate and relevant. So lots to do. I think grateful for those board members who've noted it's a good start. That's absolutely where we think it is, and there's lots of work to do. So look forward to developing the report and co-producing that. I think we also mentioned sort of experience and citizen data as well as a key area for development. So I'll go away and start to work that into our plans and offer out invites to develop that. If there are any further comments on the larger reports on reflection that people want to send over to me after the meeting, please just feel free to get in contact. Thank you, Chair.
And there's a second bullet point under your item. Have you covered that as well?
I have not, Chair, I'm afraid. That's
Okay.
a whole other presentation.
Okay.
Okay, so the second presentation...
And just if you wouldn't mind putting the microphone a bit closer, please.
Close, yeah, it's kind of squeaking a bit in protest. Okay, so the second presentation I've got for you this morning, Board, is a summary presentation for the ICS's operational plan for 22-23. So just by way of context, the NHS every year issues operational planning guidance, both to its providers and also to its CCGs, and latterly it's asked ICSs to lead the planning round on behalf of its footprint, involving all of its providers and commissioners. And so the planning round tends to begin some point in the winter. There's a long tradition of the planning guidance being issued on Christmas Eve in the NHS, and it's usual that the plan is concluded around March time. This year, I think recognising the coming of ICBs, we were actually given until the 20th of June, so that's why you're receiving this as a presentation rather than a paper, because it was only submitted just a day or so before the paper deadline. So I'm just going to take you through some very short headlines of the operational plan, and then again happy to take any questions or comments. So this is a very short summary of the key points of the areas that the plan covers. I'm going to draw out a few headlines. I'm going to hand over to my colleague John to take you through the headlines of the finance plan in a moment, so I won't say too much. I feel I shouldn't even steal his thunder and read the first bullet point there, that we do have a balanced plan. I'm sure he'll talk to you about that shortly. I'll also talk you through the workforce plan in brief, the activity and performance plan. So this slide aims to give you a sort of rounded picture that we do have an activity plan that meets the ask in the operational plan guidance, that we deliver 104% weighted, value-weighted activity. Now, you may be wondering what on earth that means. And what it means is that compared to the levels of activity that our providers delivered in the year 1920, measured against that, so obviously a period that was pre-pandemic, the ask this year is that they deliver 104%, so 4% more, but that's not just counted in terms of activity numbers, but also in value, so that it takes account of some of the more complex operations, for example, that take place, rather than just perhaps trying to do large numbers of more simple operations to meet the target. So it tries to take account of the complexity of activity that needs to be restored, and actually the need to exceed pre-pandemic activity levels because of the rising demand on the health service. The plan also meets an ambition to increase diagnostic activity, so that's diagnostic tests, everything from plain film chest x-rays through to things like CTs and MRIs, to 120% of the volume of activity that was done in 1920. There are a couple of areas where we don't meet the national ambition. We've covered some of this in the performance report already. So I mentioned that we were unable to meet the ambition to completely eliminate waits of over 104 weeks by June. And I mentioned that the exceptions were around the spinal pathways, and indeed that same problem means that we're not able to plan to fully eliminate waits of over 78 weeks or a year and a half by the end of March. That's not to say that we're not still working on solutions, and I know the Provider Collaborative are working with both inside of our patch and also with partners from outside our patch to explore every avenue for that. But we do have a small cohort of patients that unfortunately may still wait over that 78-week period by the end of the year. And I also mentioned earlier some of the exceptions around the mental health plan, where we are seeing growth in service provision, but not at a speed that meets the national asks, and indeed meets the rising demand in that sector in a number of areas. We undertake an activity called triangulation as part of our planning processes, and the purpose of that is to make sure that we have, for example, a workforce plan that meets the needs of the activity plan that we've set, and indeed that we've got a financial plan that meets the needs of the workforce and activity plans that we've got. So that's just by way of summary, and I'm just going to hand over to John now to take you through the finance plan. Thank you.
Thank you. I think we need, as a board, to orient ourselves fairly quickly in terms of where we are with finance. So, to start that process, I'll take you through briefly some of the key points from the recently completed planning process. Well, we can talk a bit more about this when we look at the budget setting paper as well. So we needed to do two things at a very high level, and one is we need to remain within our allocation statutorily as an integrated care board. The other thing we're expected to do is submit a balanced plan across the ICS, so that includes all the NHS provider organisations as well. And did we do that in terms of our planning? Yes, we did. And you can see there on the slide a breakdown across the provider organisations, which total a deficit of 2.6 million and a corresponding surplus of 2.6 million in the ICB. So in balance overall. In terms of capital expenditure, we have a plan which is currently above our allocation, but that assumes slippage, which is reasonable in the field of capital expenditure. But one point to note is we're still finalising those numbers with NHS England, so there are live conversations going on there. I think it is interesting to note the change in this year when compared with last year, where we saw I think an easier financial position in terms of the services that could be delivered across CCGs and providers. And at a very high level, what we have this year is a little bit less income in the position and also increased pay costs, particularly as providers are trying to build their capacity in order to address some of the things that we've been talking about. Another interesting point to note, I think, in the plans is the level of exceptional inflation. And this, in particularly the 42 million that we've identified there, is in relation to energy costs and PFI costs. PFI costs tend to be linked to RPI, so linked to inflation in some form or other. And I think we're probably well aware of the increase that we've seen in energy costs, and we have been shielded a little bit from that because most of our providers are in fixed energy contracts, which means we haven't quite seen the full impact of that. So there's a lot to look at there as we move forward. We have planned efficiencies across the NHS of 3.5%. That falls into our risks in terms of delivery. That is quite a challenge. Other risks that we've identified are around the elective recovery funds. So Jacqueline mentioned needing to hit that 104% in order for us to earn that resource. So, you know, there is a risk that if we don't hit that, we won't earn that resource. Looking slightly further forward, in the plans, there's quite a reliance on non-recurrent measures, so things that are in place for this year, but we will need to find a solution when we look forward to future years. So, you know, just to be clear on this and avoid any doubt, we are in a very challenging financial environment here, and delivering these plans across the patch will require some very careful management over the next few months, and alongside that, a really robust planning process to allow us to get on a sustainable footing for next year and beyond, so that we can deliver the things that we want to deliver and the things that we've been talking about today. So I'm going to stop there and hand back to Jacqueline.
Chair, do you want me to finish the presentation and then take questions on the whole thing? Yeah, okay. Thanks. Okay, so then just to take you briefly through other key aspects of the plan, this is a very high-level workforce plan summary, and what this is telling you is that within our plans, we are aiming to increase our substantive workforce, that's people who have a contract of employment to work for the NHS, by 3.8%. And that's an establishment change of 1.39. So that means that we're both planning to both recruit to existing vacancies and create additional posts as well. And then if you look at the bank and agency figures, you'll see that as we're planning to be successful in filling quite a lot of vacancies, so we are planning a correspondent reduction in our bank and agency spend. And at the bottom there, you can see that within our plans that specifically for primary care, we've got an ambition to grow our workforce by 1.26%. I'm not going to go through these slides in a huge amount of detail, Chair, because I think we covered a lot of this in the performance report, but I thought it was important and helpful to go through all of the key national asks, that's to say the things that the NHS nationally, NHS England, has set as requirements for the NHS at large to deliver during 22-23, and then just draw out what the ask is, what our local plan is, and whether it meets the ask or not. So I'll just give you a couple of short exception reports, if I may, where we haven't covered them in detail before. So the first blue, interesting choice of colour, X there, is the aim that we have a 25% reduction in outpatient follow-ups by March 23. And you can see there that we're some way off, that our plan is actually to reduce down to 94.2%. And again, this is relative to 1920. I think this has been a target that's been found challenging up and down the country for a number of reasons, partly because organisations are carrying follow-up backlogs in the wake of the pandemic, but also, obviously, as we increase activity relative to previous periods, so that comes with a quotient of follow-up activity. There are opportunities to do some transformation in this space, and I know there's a lot of activity going on in the providers looking at new pathways and new ways of working. This target is in action from March 23, so you know, there's still opportunity to do further work on this, and I know that's going on. I think I've covered the long waiters and cancer exceptions in my earlier presentation, Chair, so I'll move on. This is a summary of the national ambitions for mental health, and this gives you the sort of detail behind the commentary that I gave you earlier in the performance report, that we have some challenging targets around increasing capacities across a range of our mental health services, We have met a number of them, but there are others where we're not quite meeting the ambition. In some we're getting pretty close. I did follow up, for example, on this slide, there's an ambition that 2/3 of the estimated number of people with dementia in England should have a diagnosis and an appropriate post-diagnostic support arrangement in place. So 2/3 would be 66.66 reoccurring, and our plan is 66.4. So just shorter of the ask. I understand that there's been a huge amount of work on this. My colleagues to my left may know more about it, and there's still further work going on, but that represents a very detailed plan, and so that's where we've landed. But you can see that the services are working hard to meet these targets, and no doubt we'll be covering this further in future meetings. There are recovery plans in place for those exception reports. Okay, and then this is a range of other targets that sit in the operating plan guidance this year. The only one that we've got an exception report against here is that the increase of annual health checks for people aged 14 on over who are on a GP register as having a learning disability. And the national aim is that by next year, by 23-24, that will be 75%. We've got a pretty long way to go on this, and I'm sure this relates to some of the earlier conversations we've been having around the pressures in primary care, and no doubt we'll be doing further work on this as a system over the coming weeks and months. Lots of detail on this slide here, and I'm happy to take questions, but this just gives you the real detail behind the various service lines or points of delivery that make up the recovery plan for the 18-week referral to treatment target. So you can really see in detail there at the top the amount of activity that we're looking to deliver relative to 1920. And so in total, 100 for 4% in terms of, if you like, counting individual activities. You've also got the ambitions there around non-elective, around A&E, and at the bottom there, you've got the specifics in terms of the planned reductions in waiting times against those long waiting targets. I think my colleague John covered a bit of this, but this is a very high-level summary again of the key risks, which is underpinned by a much more detailed risk register. John, you mentioned the challenges in the financial position, both in terms of reviewing capital and also that key point that delivering some of our income this year is contingent on meeting that 104% activity plan by value. We've already touched this afternoon a number of times on a range of workforce issues, and so that's not just about whether we've got sufficient numbers of staff, but as Annie was referring to earlier, how our staff are feeling after a number of really tough years and how that might affect both recruitment and retention going forward. Clearly, as we sit here today, we haven't co-produced and landed that integrated care strategy, and so there are some risks around us making key decisions in the absence of that, and we're very cognizant of that. We know that urgent emergency care pressures remain extremely high, and also that we continue to have a very high number of medically fit patients in hospital awaiting discharge, and that of course relates to the concomitant pressures in our care system across the board, both in domiciliary care and in our care homes. And we've also already looked at some of the data around some of the handover delays and response time issues for our ambulance service. So that remains a key risk for us. Our urgent and emergency care network and our individual providers with colleagues and partners in place are working tirelessly on this, but we do remain very concerned about the pressures across the system. Similarly, we are managing some significant pressures in mental health service while trying to deliver those long-term plan commitments, and we recognise the impact of the long waits in some of those services. An overall risk, you'll not be surprised to hear in recognition of those pressures, is how do we strike that balance, meet those urgent emergency care pressures while continuing to sustain recovery of the elective service volumes and reducing waiting times. So real high-level set of risks there, but I thought it was just useful to round all of that up and, of course, draw out the interrelationship between those matters. So I think that's the very quick summary. Okay. Thank you, Chair.
Thank you very much indeed, Jacqueline. And I think just to emphasise that in relation to the first part of your presentation and this second part, that this this is the profile that we've inherited, not just as far as performance is concerned, but the sort of metrics that are used and the way they're presented. So I think we've talked internally quite a bit about having trying to get a very transformative approach to data and metrics, which gives much more rapid and clearer insights. So, and Graham would have a big part to play in this. So, that's certainly one of my priorities as well as Sam and Jacqueline and the team. So we hope next time you see it, the stats will be punching you on the nose rather than having to look back and see some of the detail. Okay, so any questions on that part of Jacqueline's presentation? We had a very full discussion on the first bullet point. Anything that anybody wanted to raise there? And one bit of context which, John, you could provide us with. When you did this important work in balancing the financial situation, what's the position around the rest of the country, just to know how good or bad we are?
It has been a long process in terms of getting here, and as Jacqueline said, the plans are normally done much earlier in the year, and part of that was trying to address that gap across the whole country. I think we were relatively at the better end of things in terms of the whole country, in terms of the gap we had proportionately. But of course, we are the biggest ICB, so I think there are still issues to address nationally, as I understand it. Most systems now have got to a balanced position, so really the question is about the level of risk that systems are carrying in terms of delivery. I think we are at the better end of things, but as I said, it's still quite a challenging environment.
So when everybody went to meet the NHS Director of Finance, you were one of the ones that got coffee? Okay. Dave.
Virtual coffee, I think it was, yeah.
Yeah, thank you, Chair. And I think there's a huge amount of work gone into this, which we just need to recognise. And I think you touched on it, Jacqueline, when you're presenting this. This is very, very NHS focused, and this is somebody speaking who's worked for the NHS since he left school, which is not that long ago. But seriously, I think in terms of this is necessary, but actually in terms of the ambition we've got as an ICB, and thinking particularly of local authority and other partner colleagues, it's not sufficient to get to where we need to, but we do have to focus on this in the here and now to give us the headroom to get into that wider piece in terms of meeting the health inequalities and the engagement that we talked about earlier on. So, important piece of work, but we need to go much, much further beyond this to meet our ambitions.
Okay, thank you. Neil? Oh, sorry, it's Jackie. It's difficult to see who's lined with.
Yeah, so, I mean, I think that this follows on from really what David said. I think that there is something about, obviously it feels like a reasonably strong position, but I think that in terms of kind of where we go next, there is something about, particularly from a care perspective and social care perspective, understanding the shift in activity, particularly what feels like from health to social care, but I'm sure that health would say vice versa. So there's something about how we understand that. I think that the other part of it is as a system that kind of, I think that whilst, there is a clear, coherent plan around this, I think that the other part of it is particularly from an adult's perspective, where you've got significant change ahead around some of the reform. So some of the issues about charging reform, some of the issues about fair cost of care, and the issues that John had alluded to around CPI and all of that has quite a significant implication in terms of local authorities. So there is something about how we jointly understand that across the whole of the system.
Yeah, thank you very much. Mike?
A couple of points. Firstly, regarding the outpatient follow-up metric, we just have to be careful with some of these metrics that we don't end up shifting work from one part of the system to another. So outpatient follow-up, I think we all recognise the antiquated model of the NHS of sometimes automatically following up patients is not necessary, and the innovations regarding patient-initiated follow-up, I think, are really welcomed. But it's about co-producing these new innovations in a way that makes sure that it doesn't ripple, in particular, into general practice in this instance if patients aren't followed up, because that can create extra work in the system in a hidden way. And then the second point regarding the very ambitious targets for the bank and agency staff. So I guess a direct question as to what incentives are we putting in place to achieve those drops of almost 50% in some cases. I feel that's very ambitious. I'd love to see it happen, but I'm just a bit concerned that it does sound very, very ambitious.
Okay, thank you. Anne.
Thank you, Lee. Just building on Jackie's point really in terms of the care market, but also thinking about discharge in the local authorities, because the majority of the work that we do is within communities, with individuals. It's not all about hospital discharge, so just trying to make that point in terms of what else we can do and how we bring that into the fore. Thank you.
Thank you. And David.
Thank you. Just a very general point. Are we spending sufficient time on social care, care homes and care in the home, because that is so important for the health service? And most of the debate has been on health and social care and the implications, the planning for that. Not too much has been mentioned. Have we got the balance right in terms of health vis-a-vis the social care aspect of life in the health and care services?
Jackie, you look like you want to come in on that point.
Yeah, so I think that there is an opportunity through this to kind of add that picture into this and try to balance some of the kind of the issues that we've got between acute and social care. So that's kind of one opportunity that I think the ICS has got. I think that the second issue is, and John will tell us if I'm wrong, but my understanding is that predominantly the additional funds that are coming into local authority, and in particular to adult social care, will be directed via the ICS. So again, it opens up that opportunity to really understand what some of the issues and priorities are, but also to make sure that the resources are allocated appropriately.
Okay, thank you. Neil.
My point was very quick on the LD health checks. Historically, performance at this time of year is usually very poor, and there's a mad rush in Q4, which is not the right way to do it. I've had conversations with our Learning Disability Network, and we're looking to try and get a better approach. The vast majority of the health check doesn't actually need to be done by general practice. We really would like to, and I went to a really interesting presentation which was hosted by Bola Boala from Health Inequalities Lead at NHS England, and there's some models around the country where the voluntary sector are doing 90% of the health check, and then just referring individuals on to health services if and when needed. So there's some new ways in which we can do this, but we are actively looking at it. It's a big priority.
Okay, thank you. Mark.
Thanks, Chair. Just thinking about some of the discussions we've had about workforce and thinking about the comments that Anne and Jackie have been making, I just think there's a real opportunity for us to think about workforce development jointly between the NHS and the care market. Organisation and our new ways of working together.
Thank you. Sam.
Thank you, Chair. I just really wanted to kind of talk about risk and strategic priorities, because I think it's really helpful that we've got the baseline predominantly of the NHS data here, and I think we're all agreed that we could have a much more balanced view of the whole system. We really hear on a daily basis the challenges, particularly in the care sector. Whilst the NHS workforce, we're expanding, the care sector is getting increasingly challenging, particularly as people take decisions to leave the care sector to go and work for other organisations where the hourly rate of pay is much higher than we're able to offer. So we have some opportunities. I think what this data though says to me is we've got to change the way we do things. We've got to transform the system. We've got a situation where our hospitals have never been working with the level of occupancy that they're working with today. We've heard about the pressures of the elective recovery plan, and I don't think we have fully understood, therefore, the knock-on implications for our social care colleagues in terms of increasing that activity and the implications really for the wider care sector, but also on social care. I think what this data is really telling me is the importance of our strategy. of our strategic work over the next few months to think about actually how we're going to do some of this differently, because we cannot quite simply, particularly in the constrained financial environment. I think, John, your point, we are this year dealing with slightly less resources than we've had in previous years, keep working the system in terms of the way it's set up, in the way we're doing it at the moment. So I think for us as a board, strategically, the strategy is a big priority. And I also think it's really helpful to see our risks set out. And I do want to recognise the risks in terms of the financial plan that we've put together and the efficiencies. I do think it's a stretching but realistic efficiency target. And Chair, John and I are aware of other systems that have 4 to 5% efficiency targets. We didn't think that would be realistic or achievable, but nonetheless it's still stretching. So we'll have to keep a very close eye on the finances on a month-to-month basis. But for me, this signals the need for transformation and change across the system.
Ken, how does this compare to the sorts of points that the foundation trusts are looking at?
It, to a large extent, mirrors exactly the conversation we're having. I think that all of us would probably recognise that we can't keep doing what we're doing. We can build bigger hospitals, we can build more A&E departments, you call it what you like, but that's not the solution, is it? But we're in a difficult workforce position, as we've acknowledged already. Mike, you asked the question about agency spend. Yeah, there's some risk in those numbers. I'm sure John would confirm that. And by the sign of it, Sue's recruited all the consultants that are available anyway to go to Teesside if she's got 90. And that's great for Teesside, but it makes a point, doesn't it?
Yeah.
That actually that might stabilise Teesside, but undoubtedly will cause some pressures elsewhere in the system. I should add just on agency, there are some extra controls now, I think, being put back into the system this year on the spend that individual organisations can make on agencies. Now, you may look upon that as a double-edged sword. You know, if it's 10 o'clock on a Saturday evening and we need an agency doctor urgently in ED, you know what we're going to do. If we're not in a position of making sure that shift is safe, etc., etc. So there are some tensions, dilemmas, but I think, Liam, the provider sector want to do things differently. We know we can't rely on the same old style of delivery, particularly reliance on some aspects of workforce. I would say as well that there's some issues I think we should rightly be asking our national colleagues to help us with as well. So reflecting for a second or two on outpatients and follow-ups as an example. We have bodies like NICE that actually are quite prescriptive in terms of the guidance they give to some of our clinical colleagues about how they operate. So if I take a head and neck surgeon in our organisation, she will say to me that NICE is telling me that I have to see follow-up patients with head and neck cancer 10 times over a period of time. Now, I think it used to be prescribed in our standard contract that actually we had to follow NICE guidance, and most clinicians would probably intuitively want to do that. But actually we need some of those rules to change to help us also tackle some of these targets around the 25% that Jacqueline mentioned. So I think, Liam, you'll find that the mood in the provider collaborative is very much about we can't keep doing what we're doing, we've got to change. The issue is how do we get that change embedded whilst we're keeping the show on the road.
Okay, thank you very much indeed. Okay, Jacqueline, any final comments from you?
Very briefly, Chair, thank you. Again, really helpful. I would have an ambition expectation that when we sit here in 9 months' time looking at our plan for 23-24, we'll have a much rounder plan that will be reflecting our ambitions for the first year of our 5-year integrated care strategy, and we'll have that broader view of all of the priorities for the health and care service and for our population, rather than perhaps something that's sticking fairly closely to the priorities that have been prescribed nationally. But thanks very much.
Okay, well, thank you everybody for that discussion. That was very, very helpful and insightful, actually. John, I think the next item is yours.
Yeah, we've covered the first bullet in that presentation, yes. So I'll move on to budget setting, if that's okay. So under the standing financial instructions that we adopted... Are you showing
slides for this?
No, this is the budget setting paper. So under the standing financial instructions that we adopted earlier in the day, we need to approve ICB budgets to allow us to incur expenditure. This paper does acknowledge the wider ICS, but it's really focused on the ICB itself. There is some detail in the paper, but I'll highlight just a few things from the report. The first thing is the 4.9 billion allocation and that's just for the 9-month period of this year, the remaining 9 months of the ICB, and the 2.6 million surplus, which is in the plan there for the whole year. This has been prepared under national guidance, but informed by the knowledge and local knowledge and expertise of the preceding CCGs. Some points to note from the national guidance: the continued focus on elective recovery, which we've touched on a few times today, and the delivery of long-term plan objectives. The reduced COVID funding when compared with 2021, and the cessation of the hospital discharge programme. In terms of risks, and this is becoming a bit more specific to the ICB itself, but similar sort of themes to the broader ICS, the delivery of efficiencies and whether the performance in terms of overall across the ICS is sufficient for the ICS and ICB to earn sufficient elective recovery funding to cover the amount identified in the plan. These and other risks will be managed throughout the year, and we will report performance on a regular basis to the board. So we were asking for here approval of the ICB budgets.
Okay. Do people feel happy to approve that? Okay, thank you very much. Thanks, John. Right, we're on to item 10 now, and that's the CCG close down and due diligence assurance report. And back to you, Claire.
Thanks, Chairman. I think the report is self-explanatory. This is for assurance, not for agreeing. It gives you an up-to-date position with regards to the CCG close down. There's lots of work being undertaken across all of the clinical commissioning groups, and I'm happy to answer any questions.
Again, are you happy to approve that? Thank you. And we're on now to the schedule of meetings. This is for information, and I'm sure there'll be other meetings, but we are very conscious that this isn't your day job for most of you, and we will be careful about organising additional meetings and only do so if we feel they will add value. But there are a lot of things, I think, today and in our minds where a deeper dive into some of these subjects without a lot of papers and analysis would help us to get on the right road for then the executive taking work forward, whether it's very broad initiatives like rural health, coastal health. We've talked a little bit about that. I think there's some things where we could be very, very innovative, particularly with matters to do with population health and access to services, and it'd be nice to be able to do those. But as I say, we'll get you in only when we feel it's a good use of your time and your expertise. But the schedule of official meetings so far is set out there for information. We're on to item 12 now. Could I ask if there is any other business? No? Well, I think we can now conclude the public meeting, and thank you all for a very, very good and inspiring start to the work of the Integrated Care Board for the North East and North Cumbria. Thank you.